Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Association of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2023. And I am Anna Kozub, and it is my pleasure to coordinate, together with Cornelia Korzan, our session of systematic reviews and meta-analyses, which is held under the honorary auspices of Polish Institute of Evidence-Based Medicine. I would like now to cordially welcome the esteemed jury, the president of jury, Mrs. Alicja Kawalec, and the member of the jury, Mrs. Agata Grabowska. Now I would like to explain you the rules of the session. The order of the presentations will be the same as it is in the abstract book. The maximal time for presentation is about 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. During the presentation, the presenter who is presenting online is obliged to share his or her image using the web camera. And for the participants here on site, please, I remind you to stay in front of the camera in the same place as I'm standing now. And esteemed jury, I would like to kindly remind you that if you are a supervisor of the paper which is presented, you should not assess the work. Other members of the same clinic are able to assess the presentation, and the assessment will be then verified. All the presentation and the discussions must be run in English or Polish. And I would like to remind that if the work is presented in English, the discussion also should be run in English. But if the commission asks the question in Polish, the authors of the work are obliged to answer in English. And if the discussion is run in Polish, the additional points for speaking in English will not be counted in the assessment system. And we kindly ask our jury to assess the substantial value, the way of presenting the research, the form of discussion, creative own contribution to the work, and the evaluation of works will be held with the usage of electronic system. The member of jury will fill in the form with the usage of this device, and then the grade will be sent to the server of the organizing committee. As the session coordinators, we mark in the assessment online system whether the presenter respects the time limit of the presentation and just the usage of English language. The speakers will be granted additional plus 20% of obtained points for the presentation and discussion in English. When the session ends, we kindly ask the jury to assure if all the marks have been saved correctly, because if they are in green color, not in a yellow one in the system. So now to begin with, I think we can start with the first presentation. I would like to ask to present the paper Benign Thyroid Diseases Treatment Using Radioiodine I-131 Methods and Aspects of Radiosurgical Protection. Do we have this person here or online?
I'm here. Hello.
Okay, so can you share your screen, or we should just...
Of course.
You can share? Okay.
Yeah, I will share my screen. Okay. And let me just turn on my camera. Okay. Hello. Okay.
Okay, we can hear you, and maybe I will... Okay, so you can just... So you managed to switch the slides, I think, just by yourself. So
okay, I think it works.
So you can begin just now.
Okay. Hello, everyone. Dear Commission, ladies and gentlemen, my name is Andrzej Zuzak, and I represent Medical University of Lublin, Poland. Today, I would like to present you my work titled Radiation Protection for Patients and Medical Staff in Treatment of Thyroid Radioiodine. Here I want to present you the method of this work. To gather the information about this medical topic, I used a PubMed database with following search terms, which are radiation protection at treatment with radioiodine 131. I also followed the international guidelines made by ICRP. The aim of my work is to present the methods of radiological protection and to discuss the method of treatment with this radioactive element. So let's begin with a quick timeline of radioiodine treatment procedures. On following pictures, you may see two godfathers of this treatment. Man on the left-hand side is the Saul Hertz, American inventor of this treatment method, and Hal Enger, who designed and produced gamma camera. This device absorbs the gamma waves so that we can examine which part of thyroid gland is active or not during the procedure called scintigraphy. But the basic question is, why do we use those treatment methods? And the basic and the most common disease that we deal with is Graves' disease, called also hyperthyroidism. This disease can be cured also by another methods, such as pharmacological and surgical. Here we have the numbers of how much specialists in Europe and United States chooses this treatment method. Treatment also depends on the severity of this disease and its stage, and aftermath, such as costs of treatment. We have to consider that every method has its own indications, pros and cons, which step over the topic of my today's presentation. On the following slide, I would like to present you the pros and cons of this radioactive iodine treatment. Most significant pros are we have the rapid control of the disease. Cure rates oscillates about 80 to 90%, and that the side effects of this therapy are minor. Most significant cons are the patient after this treatment stays in permanent hypothyroidism, and he is obligated to take medicine every day. Others are that the treatment can aggravate the severity of orbitopathy, as well as it's forbidden to perform this procedure during pregnancy. What other diseases can we treat with this method? So, as I mentioned before, indications to this treatment is Graves' disease, but other are toxic adenoma and toxic multinodular goiter. We have also to consider the aspects when making the choice, such as age and clinical conditions, also anamnesis. But what exactly is radioiodine? This is an artificial created drug which produces radioactive waves. These products present huge affinity to the thyroid gland, and during its nuclear transformation, it produces beta radiation, which is the main therapeutic factor of this isotope. This radiation is strongly absorbed by thyroid gland, and this product eliminates hyperactivity of thyroid gland. This procedure provides the dosage on level of 2 millisievert. In comparison, the dosage of CT scan is 25 to 30 and even 35 millisievert. But what about the protection? Protection of staff and patients dealing with the radionuclides are ruled by the golden rule of radioprotection, which is actually an acronym. ALARA stands for as low as reasonably achievable. On this slide, I want to show you how we can protect ourselves from the radiation. On the next two slides, we'll discuss the role of protection, patients, and staff. So a patient protection has to be justified and noticed. We cannot expose people to radiation without the rightness of this action, as well as we have to notice what dosage of radiation did the patient get. The second rule is continuation of the previous one, and it's said that every dose has to be appropriate. Every technician calculates personally the doses for a patient. Next rules are, if possible, the influence of this radiopharmaceutical distribution should be carried, for example, in local liquid. And while choosing the radionuclide, we have to choose one which has the lower activity. For example, in thyroid scintigraphy, we use rather TechNet than iodine. And the fifth one, as I mentioned before, the time of inception should be shortened as much as we can. Of course, it's completely understandable to hear patient concerns about radioactive element therapy. When it comes to discussion about radioactive elements and radiation, most of people think about Chernobyl incident and other treats. The most important thing is to dispel all the patient concerns in a scientific and a cultural way, and remember they always have a right to quit the treatment. Some patients are also worried about if this treatment can shorten their lives, but it's not true. It's evidence that the single therapy shortens life for circa 6 hours. But this whole treatment does not count that after treatment, the patient quality of life is better and the estimated time of life expands. By the way, there are some more dangerous situations, such as car accident or smoking. Following slide presents you the rules of protection of stuff, which the most important are time, distance, and covers. Also, every technician, every man who works with radionuclides has to have the electronic personal dosimeter provided. This supervision is carried out by annual checking of the absorbed dose in these EPD devices. And following the recommendation of ICRP, the annual effective dose should not exceed 50 millisievert. The radiological protection in Poland is based...
Excuse me, your time is over,
yes,
so
yes,
could you come to the conclusions?
Yeah, okay, yeah. So to conclude, radioiodine treatment is relatively safe when it's done in the correct way. To help the medical staff and patient, we have a lot of rules according to radioprotection, which most important is ALARA. I shortly discussed the most important ones. Unfortunately, due to the lack of time, we cannot study through all of them, but the safety of medical personnel and patients is ensured by safety procedures, proper training, and proper organization of work in a nuclear medicine laboratory. Thank you for your attention. Excuse me for exceeding your time.
Thank you. Now I would like to invite you all to ask the questions and discuss the presented paper. So I'll pass the microphone just now to the jury members so that they could ask you a question.
I have a question to your database you used in your researches. Is PubMed the only one database you used?
No, I used also Scopus database, and as I mentioned before, I also used the guidelines of IRCP, which are published annually. And this is the most basic, I think, paper that every nuclear medicine work is basing on during producing their own rules.
Okay, thank you. Hello, so I am the member of jury. My name is Alicja Kawalec, and I would like to ask you one question about the methodology too, because as you may know, in the for a work to be called systematic review, it has to pass a very thorough and very special process of the inclusion and exclusion of the works that were in the work. So can you tell me more about the inclusion process of the articles that you used in your work?
Okay, so about inclusion. Okay, so I used only the most recent ones, which have the most citations. I excluded the old ones, older than 2010. I also used the book of nuclear medicine, which was published in 2016.
Okay, thank you very much.
Thank you very much.
Thank you for this discussion. And now we will just move on to the second paper. So I would like to welcome the work just autoimmune NMDA receptor encephalitis as a cause of secondary psychosis, a case study review. Do we have the author present or just online? Or not? So if there is... Okay. So if there is not the second presentation, so now I would like to move on to the third presentation, the prognostic and therapeutic significance of expression of oh, I can see. So there's a problem. So can we solve it just now, or we should ask someone to help us with the camera? Give us a minute. Okay. Is this better or not really? So what we should do now? Oh, okay. I can see it's almost okay on the computer, but now we do not have the vision at all. Yeah. Switch on the light. Oh, that's okay now, I think. So we can switch off. Yeah, okay. So I think we've solved the problem. So thank you very much. So I would like to ask whether we have the presenting author of autoimmune NMDA receptor encephalitis as a cause of secondary psychosis, a case study review. So do we have Maria Nowak or Michał Ciołek to present your work or not? Okay, so I cannot hear any comments, so maybe we will move on later. So do we have the prognostic and therapeutic significance of expression of PD-1 in CLL, a review of recent reports? So do we have Alicja Maziarczyk or Katarzyna Kulszo or Arkadiusz Ściubak or Dominika Miazga?
Yes, I'm here.
Okay.
Good morning, everyone.
Okay, so can you share your screen? So that
Yes, I will share my screen now. Can you see my screen?
Yes, we can see your screen. So if you are ready, you can start just now.
And are the slides changing?
Yes, they are changing.
Okay, so to begin with, the aim of my presentation is to discuss the significance of PD-1 for the effective treatment of chronic lymphocytic leukemia. Data was collected from PubMed and Google Scholar by searching keywords CLL, PD-1, PD-L1, pembrolizumab, nivolumab, and durvalumab. CLL is one of the most common types of leukemia. In the course of the disease, there is a clonal proliferation and accumulation of mature lymphocytes in the blood, bone marrow, lymph nodes, and spleen. The incidence rate is 4.9 per 100,000 people per year. This disease mainly affects elderly people. Programmed death receptor 1 is a receptor that inhibits T-cell activity in peripheral tissues. Thus, it limits the unfavorable immune response and enables the maintenance of immune tolerance. However, it may contribute to the development of tumor cells. Programmed death ligand 1 binds to PD-1 molecules. Its expression usually occurs during inflammation on some T and B lymphocytes, dendritic cells, and epithelial cells. Programmed death ligand 1 is also overexpressed in the tumor cells and in the tumor microenvironment, where it promotes activation of proliferation and survival signaling in cancer cells. When it comes to the role of PD-1 expression in the course of CLL, the upregulation of PD-L1 expression on tumor cells causes depletion of T lymphocytes, reduction of T lymphocyte function, and avoidance of cytotoxic T lymphocyte responses. In consequence, it maintains an immunosuppressive microenvironment of the tumor. Now, I would like to present PD-1 as a prognostic factor in CLL. Firstly, studies have shown increased expression of PD-1 molecules on T cells in the blood of CLL patients compared to healthy subjects. It has been shown that as the stage of CLL according to RAI classification increases, the level of PD-1 expression in patients increases as well. There is also a correlation between the amount of PD-1 molecules on CD4 lymphocytes and the level of lymphocytosis and white blood cell count in patients. Moreover, patients who achieved full remission had a baseline lower level of PD-1 expression compared to patients who achieved only partial remission. And additionally, an increased number of CD4 cells with PD-1 molecule is associated with particularly relapsed and refractory cases of the disease, and with a significantly shorter time after which treatment needs to be started. Summarizing, the higher amount of PD-1 expression on T lymphocytes in CLL patients is associated with a more severe clinical course of the disease. Now I would like to present PD-1 as a therapeutic factor in CLL. There are various monoclonal antibodies blocking PD-1 molecules, which are already used in the treatment of various neoplasms, including lymphomas, and these antibodies include pembrolizumab, nivolumab, and durvalumab. This slide presents the most important studies on these antibodies in CLL treatment. And as you can see, various dosages and combinations have been tested. And now you can see the results of these clinical trials. Efficacy has been tested on severe cases of the disease, such as relapsed or refractory CLL or CLL with Richter's transformation. And the highest response was achieved in patients who received a combination of durvalumab at a dose of 1,500 milligrams and ibrutinib 420 milligrams. However, comparable effects can be achieved by administering ibrutinib on its own. When it comes to conclusions drawn from these clinical trials, pembrolizumab has been shown to be effective in the treatment of CLL with Richter's transformation, particularly in patients with high PD-1 and PD-L1 expression in the tumor microenvironment. Nivolumab showed partial efficacy Hence, further long-term studies on a larger group of patients are needed to define its applicability in the treatment of CLL and CLL with Richter's transformation. And treatment based on the use of durvalumab was not associated with achieving any additional benefits for patients while bringing many side effects. Summarizing, PD-1 is an important prognostic factor in CLL as an association has been shown between elevated blood levels of PD-1 and the severity of the course of CLL. PD-1 blocking monoclonal antibodies, including pembrolizumab, nivolumab, and durvalumab, demonstrated partial activity in the treatment of CLL, including relapsed and refractory CLL and CLL with Richter's transformation. And there is also a positive correlation between the amount of PD-1 and PD-L1 expression in the tumor microenvironment and the amount of response to pembrolizumab treatment. And thank you for your attention. This is everything I prepared for this presentation.
Thank you very much for your presentation. Now I'd like to invite our jury to start the discussion based on your work. So I'm moving the microphone to jury.
I would like to ask you, could you tell some more information about your methodology despite database and despite keywords? I mean, some information about your process of your researches, about inclusion and exclusion criteria.
Yes, so to find good works for this therapeutic, the role of PD-1 as therapeutic factor, I included only new works. So the inclusion year was newer than 2015. I also included only clinical trials, so I didn't include any case reports or reviews or anything, only clinical trials. And all of these works had to be on CLL, but some of these had also other neoplasm, other hematologic malignancies. But from these, I only chose the data which was about CLL, so that results were only about CLL.
Thank you. Okay, hello, and I would like to ask you one quick question. Why do you think that your work brings some novelty to the topic? Can you just make it quick? What is new in your work?
So I would say new is that PD-1 is a prognostic factor. So I think that we can use the level of PD-1 expression in patients to qualify them for different therapies. However, new is also that these antibodies, which are based on blocking PD-1, are not as effective in the treatment of CLL as we thought they may be, because we used to think that these monoclonal antibodies could really help patients with CLL, because PD-1 is an important factor in the course of CLL. However, based on these clinical trials, we now see that they are not as effective as we thought they may be.
Okay, thank you very much. So this is the end of this discussion for this work.
Thank you.
And now I would like to invite our next author. Do we have one of the authors of the work titled Benefits of Treadmill Training for Patients with Down Syndrome, a Systematic Review? So do we have Michał Ciołek or Karolina Kamińska with us or online? I will check it. I don't think they are just with us now. So in this case, I invite the authors of the work titled Okay. So we can just you have a pointer just here, if you like. So here you have the pointer. So you can change your slide just there. Your microphone, and you can.
One moment. Okay. I would like to extend a warm welcome to distinguished professors, jury members, and fellow students in attendance. Here we will be discussing arteriolusoria, a marker of fetal abnormalities and the cause of multiple clinical manifestations. My name is Kamil Kania, and together with Radosław Karaś, we are third-year medical students in Silesian Medical University in Katowice. The work was created under the supervision of Dr. Tomasz Lepich, who provided us with valuable guidance and support throughout the entire process. Let's begin. The aortic arch gives off three large arteries. A common anatomical defect of the heart and large vessels is arteriolusoria. This is when artery branches off. To już sekundkę. Okay, so this is when the artery branches off directly from the aortic arch as a fourth branch behind the left subclavian artery, or form the proximal part of the descending aorta. The ARSA, aberrant right subclavian artery, then follows the aortic arch in an upstream and rightward direction, crossing the trachea and esophagus in its course. In most cases, it runs behind the esophagus, sometimes between the esophagus and trachea, or less before the trachea. In its origin, the diameter of arteriolusoria is about 12.9 millimeters at the point of crossing the esophagus, and trachea it's 9.9 millimeters, and after giving way to the rib chest trunk, it's 8.4 millimeters. Okay, the first description of this anatomical variation was made by Honlot in 1735. Next important date, which is important to mention, is 1936, when Kommer described this diverticulum that gives rise to arteriolusoria and presented the first X-ray of the anomaly. Arteriolusoria is a relatively rare condition that affects only about 0.5 to 2% of healthy individuals. Interestingly, it is more common in men than in women. However, when ALSA, aberrant left subclavian artery, is present, it occurs 2 times more common in men than in women. In significant percent of cases, it is associated with Commerell's diverticulum. Another common finding is a common trunk of the common carotid arteries, bicarotic trunk, which is present in nearly 50% of cases. Additionally, in a high percentage of cases, the presence of arteriolusoria is frequently observed alongside heart defects. The slide provides information on the association between chromosomal defects and arteriolusoria. Arteriolusoria is a condition that is more common in individuals with chromosomal aberrations. For example, it has been found to occur more frequently in people with Down syndrome, DiGeorge, Edwards, Turner, Patau, Angelman syndrome, and mosaicism of chromosome 2. The prevalence of arteriolusoria in this population is not well established. but this condition has been identified as potential risk factors. Here we have the ultrasound of fetus in 13th week of pregnancy with ARSA. ARSA is diagnosed in fetuses using ultrasound, as we can see. This examination can visualize the right subclavian artery in the second trimester of pregnancy in most of the cases. As we can see, ARSA is in here. During the examination, it is worth to note that the course of the azygos vein and the hemiazygos vein, and sometimes the right vertebral artery, which may resemble the arteriolussoria on imaging. Arteriolussoria is not a specific marker in this examination, but in prenatal examination can be seen, but it doesn't mean that the genetic defects can also occur. Arteriolussoria can cause a range of symptoms, including dysphagia. The presence of arteriolussoria alone is not a direct cause as dysphagia, as I said before. Since the esophagus and trachea bend abdominally, and oh, sorry, I didn't. Yeah, now we're talking about that. The compression of the arteriolussoria of the esophagus mostly occurs at the fourth thoracic vertebral level. Other symptoms associated with ARSA can also include a chronic cough, arterioesophageal fistula, and pain in the sternal area. It is also important to know that breathing disorder accompanying ARSA occur mainly in children. This is why their trachea is less rigid in adults, and it's more prone to deformation. Next, we note changed sensory function of the upper limb, cyanosis, recurrent respiratory infections, slow development of the child, and adult malnutrition. Thank you for your attention. I hope this presentation has provided valuable insight into this association between chromosomal aberrations and arteriolussoria, as well as the potential symptoms and consequences of this condition. If you have any questions or would like to discuss this topic in more detail, please don't hesitate to ask questions. Thank you.
Okay. So thank you for your presentation. Please stay here and I will just move on the microphone to the jury, but please stay here. Now I think we can start our discussion.
Could you tell us which types of articles did you take into consideration in your work?
The two databases of articles, two databases of articles which we were searching for was it was Medline and Cochrane Library. The types of the articles which we searched was the meta-analyses and also the systematic reviews on ARSA, such as also we search for the original works which were describing ARSA as well.
Next question.
Hello. So I would like to ask if you, how do you think that your work can impact the diagnosis of in the gestational age?
I think the impact is very important because, as I told before, the arteriolussoria can be important marker of fetal abnormalities which can cause. I think it's very US ultrasound examination is very cheap examination which you can provide everywhere you want, every time you want, and it doesn't need patient to be well prepared for this examination. So I think it's a very important question, that a very important thing that we can provide this examination and find if patient has ARSA or no, and then wide our investigation if has any other fetuses abnormalities, I think.
Okay, so one more question.
So these 45 scientific publications which were included in your work was only meta-analysis and systematic reviews?
No, we got also the original works which were describing ours as well, as I said before. Thank you very much. Thank you for your attention and have a good day.
Thank you for the discussion. Now we will close your presentation just now. And now I'd like to ask whether there are with us the authors of the cardiovascular consequences of hematopoietic stem cell transplantation or online. Do we have there? I think I cannot see them as the authors because they are also an authors of the work. The next one, assessment of the sleep quality of children, adolescents, and young adults during COVID-19 pandemic. Because as far as I'm concerned, they are the same one. And also the third one, the role of circulating biomarkers in the diagnosis and prognosis of cardiovascular disease, comprehensive review. So I think if they are not with us just now, so maybe we will come back to those three presentations later. So now I'd like to welcome Zofia Spandel and the work of impact of gut microbiota pattern on the course of selected eating disorders. I think she is just with us, so in a moment we will start. And I'll also upload the presentation, so then all of us can see it. Okay, give me just one moment so we can. Okay, so you can start just.
So good morning. Thank you for the opportunity to speak at this Congress. My name is Zofia Spandel, and I would like to present my research titled Impact of Gut Microbiota Pattern on the Course of Selected Eating Disorders. So the human body is inhabited by nearly 3.3 million genes of microorganisms. Furthermore, it's estimated that our digestive system is populated by 300 to 500 species of bacteria with a total mass exceeding 2 kilograms. Microbiota can be defined as the collection of bacteria, fungi, archaea, viruses, or protozoa residing in the bodies of both humans and animals. Microbiota changes and is shaped by various factors, including nutritional status. That's why this review aims to compile scientific studies based on the relationship between the gut microbiota and selected eating disorders based on the ICD-11 classification. We analyze the results of animals and human studies in different health conditions using specific search phrases such as microbiota, gut, and, for example, eating disorders in a methodological tool called PubMed database. We obtained over 880,000 records after considering selected criteria, including English or Polish language, articles published after 2015, with some exceptions, and open access. We narrow it down to 111 sources, and special attention was given to the latest scientific studies from the last 5 years, which constitute over 25% of the citizen sources. Thanks to this review, we identified 9 studies showing a relationship between gut microbiota and anorexia, which is defined as chronic energy restriction leading to significant weight loss. For example, Methanobrevibacter smithii is responsible for using food as energy source for the body, so a higher number of these bacteria may be associated with the body's adaptation to low-calorie intake. Studies have also shown higher levels of mucin degraders, such as Clostridium, and a higher occurrence of potentially pathogenic bacteria such as Klebsiella and Salmonella. Additionally, it has been confirmed that E. coli can produce protein, the name CLPB, which triggers the production of antibodies that react with appetite-regulating hormones, creating the feeling of satiety. On the other hand, the analyzed studies showed that the local number of bacteria, including this mentioned on the slide, was lower in anorexia patients compared to a healthy one. This is also associated with the decreased concentration of short-chain fatty acids, such as butyric acid, which is the main energy source for colonic epithelial cells, propionic acid responsible for regulating blood glucose level, and acetic acids that prevents the growth of pathogenic bacteria by changing pH in the intestine. Other studies focused on the patterns with bulimia and binge eating disorder, and bulimia is characterized by frequent and recurring episodes of overeating with compensatory behaviors which are not present in binge eating disorder. I would like to highlight that the most studies are focused on E. coli and CLPB protein. This protein mimics the alpha MSH antigen with anorectic effect. The level of this protein in the serum depends on its concentration in the gut microbiota. As a result, increased numbers of E. coli may be associated with a higher CLPB production. And seeing this connection between microbiota and ED, we took a step further and researched details about its modulation. So it has been shown that the microorganisms in the intestine are strongly dependent on the composition and type of the host diet. In the first line, we see bacteria that can influence the physiology of the host body, for example, by controlling intestinal transit time. They take part in the regulation of neuropeptide expression, such as PYI and ghrelin, therefore affecting appetite. They are sorts of short-chain fatty acids, as I mentioned before. There's also evidence on of the influence on mood and cognitive functions. Bacillus mediates the synthesis of norepinephrine and dopamine, while Lactobacillus additionally synthesizes acetylcholine. Streptococcus and Enterococcus produce serotonin, and low serotonin metabolism has been observed in its advanced phase. Furthermore, in 2019, it was confirmed that increased serotonin production from tryptophan leads to reduced back depression inventory scores after administration of Lactobacillus helveticus and Bifidobacterium longum in patients taking antidepressants. And to conclude, the correlation between microbiota and selecting eating disorders does exist. Moreover, it was such an interaction regulates multiple mechanisms responsible for maintaining host homeostasis. The mentioned eating disorders remains that it's unclear whether the observed microbiological patients are a consequence or chronic calories restriction of a causative factor. Additionally, the immunization against CLPB can be considered as a potential preventive and therapeutic option of anorexia and bulimia, as well as binge eating disorders. Ultimately, probiotics are one of the ways to manipulate the gut microbiota, and especially Lactobacillus and Bifidobacterium. Also, I would like to mention that it's important to continue research on the implementation of probiotic therapy in the treatment of eating disorders to understand the role of good ecosystem and to educate society of maintaining a lifestyle that promotes a healthy gut microbiome. So thank you for the attention, and I'm waiting for the questions, if any are.
Thank you very much for your work. Please stay here, and I'll pass the microphone to our jury members.
So thank you for your presentation. I really like your methodology. It was very thoroughly presented for us. And I have one question. What was your way to sure if you in which way did you check in the studies that because you in the conclusions you suggested that the change in microbiota might be either the reason or the effect or the eating disorders. In which way would you make sure that it was not the causal factor but the outcome?
Okay, so this is a research, so that's why the authors of the previous ones like meta-analyses or just randomized control research, and it was just mentioned in the basic ones.
And based on your work, if you had to give patient the most important suggestion for patient, what would it be?
Okay, so maybe it will be very simple, but maybe as we all know, the Mediterranean diet is one of the highest in the rankings in the whole world, and it concludes like the whole grain products, also the dairy, and also like fish that are good source of tryptophan that is connected with, for example, the serotonin metabolism that was also mentioned in this review as one of the factors of anorexia. So yes, I would say like Mediterranean diet, but of course it depends if there are any other diseases that are with the patient.
Do you have any questions or not? Okay. So thank you very much for your work, for the discussion. So now I'd like to move on to the next work. Effectiveness of therapeutic drug monitoring, Kamil Możdżeń, Mateusz Kęska, Weronika Fidelus, or Victoria Suchy. Do we have someone with us online? I don't think so. So I think it's time to move on to the next presentation. The reassess potential of SARS-CoV-2 attenuation for COVID-19 vaccine development, a systematic review update.
Hello, I have a slight problem and I will be available in like 10 minutes. So I can move me to the end.
Okay, so we will just pass you to the end. I will just mark for myself this information. So now I would ask the presenters of the work named the Ilizarov technique a review. Do we have? Oh, I can see we have an interlocutor. So I will just try to open the presentation. Okay. One moment. Since the beginning, I think you can see it, the ones who are online. And are you ready or? No, you have to stay just here so they can. Oh, so we have just, yeah, started the pointer so you can show us something. Yes, so if you are ready, you can. I will try. Oh, so I think we can do it, so it's better.
Dzień dobry, witam wszystkich zebranych, witam jury. Ja się nazywam Hajnus Olaf i chciałbym przedstawić Państwu naszą pracę na temat techniki Ilizarova. Celem naszej pracy było zebranie wszystkich informacji na temat użycia aparatu Ilizarova w ostatnich 10 lat. Aby to wykonać, przeszliśmy i przeszukaliśmy bazy danych PubMed i Embase, wpisując te słowa klucze podane na przezroczu. Otrzymaliśmy 176 artykułów, z czego następnie musieliśmy wybrać takie, które nam pasowały, a więc musieliśmy odrzucić wszystkie, które miały więcej niż 10 lat i w których użycie stabilizatora zewnętrznego nie było podane. Ostatecznie wyselekcjonowaliśmy 86 artykułów. Czym właściwie jest aparat Ilizorowa? Jest to specjalistyczny stabilizator zewnętrzny stworzony przez sowieckiego ortopedę Gawriła Ilizorowa w 1951 roku. Jak widzimy na obrazku, jest on zbudowany z pierścieni, które są połączone metalowymi prętami ze sobą, które mają modulowaną długość. Dodatkowo metalowe pierścienie łączą się z kością za pomocą tzw. drutów Kirchnera, dzięki czemu możemy przymocować aparat do kości. Dodatkowo dzięki modulowanej wysokości, właściwie długości prętów, jesteśmy w stanie regulować odległość między pierścieniami, dzięki czemu możemy to wykorzystywać w leczeniu wielu patologii związanych z układem mięśniowo-szkieletowym. Wynikami naszej pracy były najczęstsze patologie systemu mięśniowo-szkieletowego, które autorzy podawali jako dobre do leczenia właśnie tym sposobem. Głównie wymieniali dwie pierwsze podane na przyzroczu, czyli leczenie braku wzrostu kostnego powikłanego infekcją oraz leczenie różnic długości kończyn oraz jakieś wrodzone wady kończyn. Dodatkowo autorzy podawali również leczenie zapalenia szpiku kostnego, czy stawu rzekomego, czy deformacji stóp, jednakże były one w znacznej mniejszości podawane. Dodatkowo tutaj na zdjęciach radiologicznych widzimy założony aparat Ilizorowa na kończyny. Jak widzimy, przesłania znaczną część kończyny, przez co ciężko jest ocenić takie zdjęcie radiologiczne. Dodatkowo na trzecim obrazku mamy widoczny znaczny ubytek kostny, co również jest świetną patologią do leczenia właśnie tym aparatem, ponieważ mamy tak zwaną metodę transportu kostnego, do której właśnie używa się ten aparat. Wynikami naszej pracy było to, że aparat Ilizorowa jest bardzo dobrą, nieinwazyjną metodą, która nie wymaga dużej opieki pooperacyjnej. Jako jeden z niewielu rzeczy czy stabilizatorów nadaje się do leczenia infekcyjnego braku wzrostu oraz niektórzy autorzy podawali, że poniżej 4 roku życia leczenie wrodzonego stawu rzekomego u dzieci na piszczeli nie jest do końca korzystne, nawet może im szkodzić. Jedynymi problemami związanymi z zastosowaniem tego aparatu jest to, że może być infekcja związana z drutami Kirchnera bądź sztywność stawów oraz to, że cała terapia tym aparatem jest dosyć długa. Tutaj na filmiku widzimy jedno z zastosowań tego aparatu, czyli jest to wydłużenie kończyny. Jak widzimy, mamy odciętą kość piszczelową, kość strzałkową, założony aparat oraz następnie rozsuwane są te pierścienie za pomocą metalowych prętów. Takie wydłużanie kończyny według teorii naprężeń Perena może być maksymalnie 1 mm dziennie. Więc jeżeli chcemy wydłużyć taką kończynę o 4 cm, musimy taki aparat założyć na 40 dni. Tak długie zastosowanie aparatu zewnętrznego może powodować wzrost infekcji oraz problemy z sztywnością stawów. Dlatego wielu autorów podawało, żeby jak najszybciej przechodzić ze stabilizatora zewnętrznego na wewnętrzny lub łączyć te obie techniki. I tutaj mam bibliografię i dziękuję bardzo za uwagę.
Thank you very much for your work. So stay here and we will start in a moment our discussion.
In Polish or pierwsze pytanie to chciałam zapytać, jakie typy artykułów uwzględniłeś?
Dziękuję bardzo za pytanie. Uwzględniliśmy wszystkie typy artykułów, które udało nam się znaleźć, więc były tam prace oryginalne, były meta-analizy, były systematic review, były wszystko, co nam się udało znaleźć, wzięliśmy pod uwagę, tylko musiało to spełnić nasze kryteria.
I mam też pytanie odnośnie do tej części już teoretycznej. Czy taki aparat ma wpływ na funkcjonowanie mięśni i jaki? No bo domyślam się, że jest zanik mięśni, jeśli ten aparat założony jest na tak długo, ale czy jakieś jeszcze inne konsekwencje i jak się to traktuje?
Ogólnie aparat tego typu jest na tyle tutaj jest plus, że możemy jak najszybciej wdrożyć całą rehabilitację czynnobierną, czy jakąkolwiek tak naprawdę, bo aparat ten nie utrudnia znacznie ruchów. Jeżeli chodzi o zaniki braku kostnego, no to jest to głównie związane z tym, że jednak pacjent nie może stawać na tej nodze, jednak musi oszczędzać i jest to faktycznie problematyczne, ponieważ jest to na dosyć długo założony aparat. Tak, jeżeli mamy na przykład założony po prostu gips, no to mamy go założonego na 2-3 tygodnie, no a tutaj mamy do czynienia z naprawdę długim czasem, więc te ubytki mięśniowe będą na pewno znacznie większe.
So thank you very much once more for your work. And now I'd like to move on. Now I'd like to move on to just to stop that presentation and to move on to the next one. So I'd like to ask if we have with us the brain adipose tissue axis, how brain and adipose tissue affect each other. Do we have the authors of this, Monika Błądek or Karolina Drygała?
Dzień dobry, jestem, tak. Już udostępniam prezentację.
So you can share your screen just now.
Czy prezentacja jest widoczna?
Okay, but not in the full. Oh, yeah, just now it's perfect, I think. So if you're ready, you can start.
Okay, jeszcze włączę kamerę, momencik. Dobrze. To witam jeszcze raz i nazywam się Monika Błądek, jestem studentką 3. roku kierunku lekarskiego i w mojej prezentacji chciałabym przybliżyć informacje na temat osi mózg-tkanka tłuszczowa. Celem naszej pracy był przegląd dostępnej literatury, a następnie wyselekcjonowanie najciekawszych kwestii dotyczących właśnie osi mózg-tkanka tłuszczowa. Jak wiemy, tkanka tłuszczowa pełni nie tylko funkcję magazynowania energii w organizmie, jak również jest też narządem aktywnym hormonalnie. Tkankę tłuszczową możemy podzielić na brązową tkankę tłuszczową, beżową tkankę tłuszczową i białą tkankę tłuszczową. Jak już wspomniałam wcześniej, tkanka tłuszczowa jest narządem aktywnym hormonalnie, co oznacza, że wydziela substancje, które są następnie wydzielane do krwi i za pomocą których może się kontaktować z różnymi innymi narządami, takimi jak na przykład wątroba czy właśnie mózg. I autorzy badania opisującego właśnie cząsteczki biorące udział w komunikacji między tkanką tłuszczową a mózgiem, postawili taką tezę, koncept właśnie osi mózg-tkanka tłuszczowa. I na tą koncepcję składały się elementy takie jak endogenne molekuły, które w ogólnym krążeniu jako wydzielnicze białka i substancje te wpływają na adipogenezę w adipocytach. I do głównych molekuł, które biorą udział w komunikacji, należą adiponektyna, CRH, MSH i leptyna. I adiponektyna jest syntetyzowana i wydzielana do ogólnego krążenia z tkanki tłuszczowej. I badania pokazują, że adiponektyna może przekraczać barierę krew-mózg i zwiększać produkcję CRH w podzgórzu, co powoduje utratę wagi i wzmożoną termogenezę bez pobierania pokarmu. Następnym hormonem jest CRH, jest to kortykoliberyna, która jest syntetyzowana w jądrach powzgórza i jest transportowana do płata przedniego przysadki, gdzie wzmacnia ekspresję genu propiomelanokortyny, co zwiększa wytwarzanie ACTH. Receptory CRH obecne są również w wisteralnej tkance tłuszczowej i powoduje to, interakcja CRH właśnie z tymi receptorami powoduje, że CRH działa jako anoreksygenna molekuła, która leży u podstaw ścieżki aktywowanej leptyną. Jeśli chodzi o MSH, jest to hormon propiomelanokortynopochodny, który wydzielany jest przez przysadkę i stymulacja MSH ma właściwości anoreksygenne poprzez oddziaływanie na typ 4 receptora właśnie na MSH. Następnie mamy leptynę, która jest przekaźnikiem działającym również anoreksygennie i leptyna ma zdolność do przekraczania bariery krew-mózg i wiąże się tam z długą formą receptora właśnie leptynowego, zmniejszając apetyt. Również receptory te obecne są w wisteralnej tkance tłuszczowej, gdzie również leptyna na nie oddziałuje, stymulując lipolizę. Ciekawym przekaźnikiem są egzosomy, które biorą udział w lokalnej i odległej komunikacji pomiędzy komórkami. I tutaj przeprowadzone badania pokazują, że skład egzosomów może się różnić. Skład egzosomów pobranych z tkanki tłuszczowej, z makrofagów z tkanki tłuszczowej może się różnić w zależności od stanu zdrowia tkanki tłuszczowej. I tak w przeprowadzonym badaniu pobrane egzosomy od otyłej myszy wszczepione do organizmu myszy zdrowej nieotyłej powodowały u niej hiperinsulinemię i zmniejszoną tolerancję na insulinę. A w odwrotnym przypadku szczepienie egzosomów pobranych z organizmu zdrowej myszy do organizmu myszy otyłej powodowały zmniejszenie objawów hiperinsulinemii i nietolerancji insuliny w organizmie myszy. Nadmierna ilość tkanki tłuszczowej może powodować również zmiany w ultrastrukturze mózgu. I tak dla przykładu u dzieci grubość kory była pozytywnie skorelowana właśnie z współczynnikiem tkanki tłuszczowej. A u dorosłych i u starszych ludzi jakby ilość tkanki tłuszczowej wisteralnej im większa, tym powodowała większe ubytki w grubości kory mózgowej i dla przykładu u dorosłych były to ubytki w okolicy skroniowej, a u starszych w okolicy potylicznej. Hiperinsulinemia związana jest również między innymi z otyłością. Otyłość z kolei według niektórych badań prowadzi do dysregulacji osi przysadka-podzgórza. Nie jest do końca wiadomo, czy właśnie otyłość prowadzi do nadreaktywności, czy nadreaktywność osi prowadzi do otyłości, ale stymulacja osi podwzgórzowo-przysadkowej powoduje wysokie poziomy kortyzolu, co z kolei stymuluje powstawanie insulinooporności i wydzielanie prozapalnych cytokin i nadreaktywność osi. Może prowadzić właśnie do wzrostu poziomu CRH, co może brać udział w patogenezie zaburzeń nastroju. I podsumowując, wzajemne interakcje pomiędzy mózgiem a tkanką tłuszczową skutkują dynamiczną interakcją jednej struktury z drugą. Niezakłócona komunikacja między jednym a drugim komponentem pozwala na utrzymanie homeostazy, jednakże jakiekolwiek zaburzenia pojawiające się w komunikacji między tymi dwoma organami mogą powodować choroby metaboliczne czy zaburzenia mikrostruktury mózgu, prowadząc do zaburzeń postrzegania i zaburzeń psychicznych. I to było na tyle. Dziękuję za uwagę.
Thank you very much for your work. So now
Jeśli chodzi o dyskusję, to mam również obok siebie współautorkę pracy.
Oh, so hello. And now I'm moving our microphone to jury members.
Mam pytanie o metodologię. Jakie bazy danych oprócz PubMedu zostały użyte i jakie były kryteria włączenia artykułów?
Przede wszystkim wyszukiwałyśmy artykuły poprzez sformułowanie Brain Adipose Axis. Wyszukiwałyśmy jak najnowsze artykuły i wyszukiwałyśmy przeglądówki, jak i również prace badawcze i używałyśmy do tego tylko PubMedu.
Jak dużo artykułów znalazłyście?
Znalezionych zostało, wyszukiwanie pojawiało się około setki artykułów, jednakże nasze kryteria spełniało około 10.
W jaki sposób wyłoniłyście te kryteria łączenia?
Sprawdzałyśmy, eliminowałyśmy artykuły, które dotyczyły innych osi oddziaływujących z innymi organami, jak na przykład oddziaływanie między mózgiem, tkanką tłuszczową a jelitami. Skupiałyśmy się na oddziaływaniu samej tkanki tłuszczowej z mózgiem i artykułów, które bezpośrednio poruszały ten temat.
Dziękuję.
Dziękujemy.
Dziękuję bardzo. Thank you very much once more. And now I'd like to ask whether we have the authors of the work called Kaplan syndrome. Do we have? Oh, yeah, I can see you. So in a moment you'll see the presentation. Wait a minute, so I will share our screen. Pointer if you need.
Okay. Good day, panel of judges. Good day, everyone. So I'll be presenting Kaplan syndrome. My name is Kencha Cynthia, and my work title is Associate Professor Elena Solomko, PhD. Okay. Background: Kaplan syndrome is also known as rheumatoid pneumoconiosis, which was first identified in 1953 by Dr. Anthony Kaplan in an evidence of intrapulmonary nodules in coal miners with a diagnosis of rheumatoid arthritis. So Kaplan syndrome is a rare condition that involves rheumatoid arthritis and pneumoconiosis, which manifests as intrapulmonary nodules with influences on the airway and interstitium, with this causing scarring of the lungs and also scarring of the lungs and swelling in the interstitium, with complications of tuberculosis. As you can see on the slide, the first picture shows a normal lungs. The second one showed a simple pneumoconiosis, which is the initial process of the pneumoconiosis, and then the last picture shows a progressive massive fibrosis. Kaplan syndrome is very rare in the recent years that it receives less coverage as compared to diabetes and heart attack in the healthcare system and research-wise. The manifestation of this syndrome occurs 5 to 10 years after exposure, with no cure other than management in treating manifestations and complications. Despite the description and well-defined clinical presentation, the pathogenesis and casualties between pneumoconiosis, rheumatoid arthritis, and preliminary changes in rheumatoid pneumoconiosis are still inconclusive, and the pathophysiology of this process still remains undefined. You can see miners being exposed to the air, infected air. Materials and method. Literature search was conducted on publications within 5 years on keyword Kaplan syndrome using PubMed, ResearchGate, Bastex, and so many. Also, a biometric analysis was also conducted on diabetes and Kaplan syndrome published articles. Results. Using the literature research database, Soviet miners in Poland showed 18.4% had various disorders and changes in the respiratory system, including the diagnosed pneumoconiosis. Miners in Poland who worked in hard mines, who in 2021, they accounted for 89.8% of all exposed people in Poland, showing 34,876 employees. In the chart, you can see a graph or a chart of the percentage of people being exposed to pneumoconiosis from 2000 to 2019. Results. Also in Poland, pneumoconiosis including silicosis is one of the most prevalent occupational diseases, with decreased numbers of confirmed cases in 2000 to 2029. Barometric analysis during the last 5 years shows 15,500 articles and reviews on diabetes and chronic diseases. But researches and publication has been made on Kaplan syndrome, but there are no analyses or bibliographic analysis on Kaplan syndrome. Conclusion: using the research database, it shows that few articles were made on Kaplan syndrome, hence making it difficult to find materials. The information analyses were lapse of Kaplan syndrome over the years, that even latest publications showed less differences for publications made years back, hence indicating less study and neglect this syndrome. It must be kept in mind that people keep dying from Kaplan syndrome every year. Therefore, this issue requires to be studied further. Thank you.
Thank you very much for your work. So stay here and we will start a discussion soon.
Could you tell us how many articles you included at the beginning, you have at the beginning, and you included at the end?
Okay, so I didn't keep account of the number of articles I included here because I did make a lot of research using not PubMed, the BuzzTech, the Scopus, and also some researches and clinical cases using National Institute Health and also Medline Plus. So there are lots of articles and research that I did. So I had to combine everything together to produce this.
So I have a question. Can you tell us more about the limitation that you may see in your study project?
Firstly, I wanted to write this syndrome based on comparing it the recent happening in Poland and also some other countries. But then again, I noticed that I couldn't find much materials on this syndrome. So I decided to write about how neglected this syndrome is. So it's one of the biggest limitations I found doing this publication or the analysis. Also, we can find a lot of cases of rheumatoid arthritis and other things. But then again, references are not being made on Kaplan syndrome, which could be the main cause of the rheumatoid arthritis. So it's something that everyone should know about. This syndrome has to be, people need to know about it. People need to be enlightened about it. Also, one of the reviews or articles I saw, it was stated that it hasn't been concluded or defined whether it is caused by immune system being suppressed or this syndrome leads to immune system suppression. So I feel further research needs to be done on this to also confirm this. And I also mentioned that the differences or the changes between pulmonary rheumatoid arthritis, pneumoconiosis, and pulmonary rheumatoid arthritis, the changes in the physiology, in the tissues or the specimen hasn't been identified yet or defined. So it's also something that people need to know about. Further researches needs to be conducted on this. As you can see, there are lots of unanswered questions on this syndrome. Yeah, thank you.
So thank you very much for your work. And just now, I'd like to invite to us one of the authors of the work titled Surgical Management of Multiple Brain Metastases of the Tumors of Unknown Origin, a systematic review. Wait a minute, so I'll open just the presentation. Okay, one moment. We will share our screen. You can, of course, use the pointer. So I think that it should work. So if you're ready, you can start.
Okay, good morning, ladies and gentlemen, dear committee. My name is Aleksandra Nasiek, and it's my pleasure to present you our systematic review titled Surgical Management of Multiple Brain Metastases of the Tumor of Known and Unknown Origin. So brain metastases are the most common intracerebral tumors. That they are much more common than primary brain tumors. And it is estimated that between 8 to 10% of the patient with cancer will develop a brain metastasis, mostly multiple ones. This gives us approximately 200,000 new patients each year. A diagnosis for such a patient is quite tragic because in the advanced cases we have limited treatment options, and we offer the patient only palliative care, and the survival rates are approximately 1 year, so not much time for such a patient. According to a National Cancer Comprehensive Network, we can propose to the patient therapies such as stereotactic radiosurgery, whole brain radiation therapies, which are the therapies from the field of radiotherapy. We can also offer the patient systematic therapy and surgery. According to a Congress of Neurological Surgeons, we can propose the patient surgical removal of the tumor in 3 different cases. First cases, these are the patients with big, large tumors with the mass effects, patients with limited brain metastasis, and patients which are suspected of the brain metastasis but without a primary diagnosis. So since now we know that the surgical removal of such tumors are not the first option, we wanted to check in our study whether it could be a safe and effective method, and maybe whether it could be an alternative to current treatment protocols. So we started our systematic review by defining our review question. Also, we specify our inclusion criteria, which were the prospective and retrospective trials with the patients who had undergone a surgery, of course, with the multiple brain metastasis. Moreover, we take into consideration patients in the adult groups, so we excluded the patients which were under 18 years old. Moreover, using PICO concept, we create our concept map, which you can see down below, and we search for synonyms and keywords, also using mesh databases available on PubMed. This enabled us to implement a proper search history. We started from initial small searches, then we proceed to the more advanced ones. As you can see on the slide, this is our advanced search example according to a PubMed database. We reported our searches due to a Prisma flowchart. Identification process was based by PubMed, Scopus, Web of Science, and clinical trials. After removing of the duplicates, we obtained 283 records, from which we excluded letters to an editor's case reports. We excluded non-surgical treatment of brain metastasis and records not concerning brain metastasis in the cancer treatment. Finally, we obtained 20 full-text articles, and in our studies, we included 12 studies. Also, we assess the risk of bias in the judgments to 3 different groups. So we have studies with low risk of bias, high risk of bias, and unclear one. We obtained studies in the date range between 1972 and 2019. Most of them were retrospective ones. The group sizes were between 34 to 492 patients in the group. What is most interesting in the studies, we can see 2 studies from 1985 and 1988, and we can compare 2 groups of the patients. One group, there are the patients with known primary site, and other one is without known primary site. As you can see, the survival rates were quite the same, because from one group this is the 25%, and from the other group this is the 20%. Most of the studies from the 90s shows that the surgical management of multiple brain metastasis can improve our quality of the life and neurological status of the patient. The last study that we found is from 2019. It's quite a big multi-center prospective study. and we have the patients with unknown primary site of the brain tumors. They were treated with the minimally invasive resection called keyhole approach, and the resection was of shallowly located brain metastasis. And this was a safe and effective method in the selected patients because in the study patients were with the good general performance. Therefore, proceeding to our conclusions, we can obtain that surgical management of multiple brain metastasis could be safe and effective method for the patient specified, such as the tumors should be located shallowly in the brain and with the good general performance. However, we did not find any significant difference between patients with the two groups, so the patients with known and unknown primary site. And still, of course, there is a need to perform more prospective trials. Yeah, this is our bibliography, and thank you for your attention. If you have any questions, don't hesitate to ask me. Thank you.
Thank you very much. So if you're a co-author, you can, of course, join the discussion side, but stay near the camera as well. So we can, I think, now just start the discussion.
A very nice presentation, but we have a question. Is any reason why did you take into consideration so old articles?
Yes, we take under consideration a lot of articles because this is quite rare and not a lot of patients undergone surgery. So we wanted to check whether it could be such an option. That's why firstly, we obtained not a lot of the records. That's why we wanted, and the records were from, for example, 1970 to 1988, most of them. That's why we wanted to have such conclusions. So we wanted to put it into put it under consideration, because if not, we would have 3 articles without any, results, good results for our study.
How many articles you had? So before, after removing the double articles, we obtained 283 articles, which you can see on our Prisma flowchart. Then after we screened our records and excluded any letters to editors, many articles that were not about the surgical removal but other methods, then we obtained 20 articles in which, after we excluded, as you can see here, reviews and guidelines, we obtained 12 articles that were good enough for our studies.
Also, I have to add that a lot of the studies were concerning non-surgical methods, such as radiotherapy, whole brain radiation therapy. So we have not much from to choose with the surgical treatment of these patients. Thank you very much.
More question, I think?
At the end, I would like to ask in which way you how did you consider the biggest limitation in your study, and how did you try to avoid them?
So definitely the limitations of our studies were, first of all, that there were not really much of them. Second of all, there was, in many studies, the groups were not large enough, so that's why we created the risk of bias table, and you could see that some of them were better than the other ones. Well, and also in the older trials, the study groups were not really divided. So the patients, for example, were all older and younger ones, and they were all put into the same, let's say, group. And there was also the division in terms of good patient performance and bad patient performance. So it was hard to distinguish sometimes, whether the study is good enough. So that's why we created the risk of bias table.
I think nothing to add.
Okay, so thank you very much for the discussion and for your work. I think we can now move on to our next presentation. One moment, I have one question on the chat, so if you could.
with 154 articles, and after screening all the duplicates and removing the irrelevant articles, we were left with 17 studies for our review.
So I would like to ask if you could sum up, why do you think that there is, can you line up the novelty and the freshness of your study?
So I would like to say, as I've already presented in the review, this is a newer and a very nice technology. It is like, but there's one limitation which I noticed in all these studies, that they had a very lesser follow-up period and the sample sizes were very less. So they need to create more RCTs and do more research in this arena to prove that yes, it is a efficacious tool. For now, I think that this could be due to the reason that a cytosol cartridge is very costly, and these kind of RCTs require a lot of funding. So this could be the reason why still there's not a concluding evidence, but the evidence we have is promising. So I feel if there is more funding and more RCTs, we could come to a better conclusion.
Thank you very much for your work. And now it's time for our next presentation. But I think you have just, it's your pen drive in here, so maybe you will come and... okay, but do not forget it. Just okay, so now it's time for our next presentation, microRNA, new perspectives for glioma therapy. And do we have this person online?
Yes, I'm here.
Okay, so you can show us your screen.
Okay.
You can start when you are ready.
Okay, so good morning. My name is Dominika Miazga and I am representing Medical University of Lublin. And the topic of my presentation is microRNA as a new perspectives for glioma therapy. For the start, what is glioma? Glioma is the most common primary brain tumor in adults. It represents about 70% of malignant brain tumors. Only half of the patients survive the first year after diagnosis. There are three common types of gliomas: astrocytomas, ependiomas, and oligodendrogliomas. They could be classified in grade 1 to 4 based on the degree of the proliferation indicated by the mitotic index and the presence or absence of the necrosis. Headaches are the most common presenting symptoms. Some symptoms depend on the location of the tumor in the brain. For example, when the tumor is located in frontal lobe, could cause behavioral changes, or when the tumor is located in the dominant temporal lobe, could cause speech problems. Possible treatment options are surgery, hemorrhagation, target therapy, and radiotherapy. Despite available treatment options, researchers have still been looking for the best methods to diagnose and treat this disease, and the potential has been found in the microRNA. They are small node-coding RNA molecules containing from 21 to 22 nucleotides. It intervenes in gene expression at the post-transcriptional level by binding to one or multiple specific mRNA targets, regulates gene expression responsible for cell proliferation, maturation, and programs cell death, plays an important role in cancer pathogenesis, we distinguish oncogenic microRNAs or tumor suppressive microRNAs. After synthesis of microRNA, there are two possible ways of its action, depending on the degree of complementarity between microRNA and mRNA. In case of complete nucleotide compatibility, the microRNA can induce mRNA degradation. We observe that in the cancer cells, there is abnormal microRNA expression profile, which could cause possible induction of unlimited replication potential and apoptosis disorders. Those connections make microRNA possible target for the glioma therapy. Data were collected from PubMed, Web of Science, and Scopus from the period 2019-2023 through searching of these keywords, microRNA and glioma. What is the potential of microRNA? Circulating microRNAs are promising biomarkers for many human diseases because of its high specificity, easy accessibility, and sensitivity. They are found in many biological fluids where they are highly stable. They shows high specificity for tissue or cell types. Specific microRNAs could determine the initiation and progression of the disease. Their levels can vary in accordance with the disease progression or with response to therapy. And they are able to cross blood-brain barrier and exist stably in the blood, either within exosomes or freely circulating. The understanding of the microRNA biology provides the foundation for effective biomarker panels with high diagnostic accuracy and clinical applicability. The isolation and the characterization of different types of microRNA using cellular and molecular biology techniques could potentially be used for improved diagnosis, prognosis, and treatment decisions. These biomarkers can serve as a target for the therapy. And microRNA in glioma. microRNA expression can be altered in the brain tumor. A variety of mechanisms, including epigenetic defects and mutations in the machine of the biogenesis. And the genes targeted by the regulated microRNA in gliomas are involved in many pathways, including autophagy, invasion, and angiogenesis and drug resistance. Since microRNA have multiple targets in different tissues, they may have oncogenic or anti-oncogenic effects depending upon all the biological context. And there are some microRNAs which are responsible for the processes of the biogenesis of glioma. And the processes are invasion, migration, survival, apoptosis, proliferation. And now we have the most promising microRNAs to be effective biomarkers for glioma. And this is microRNA 21, 10B, 222, 451, 145, 128, and some others. And it is important to difference that this is the overexpression of specific type of microRNA, or if it's down-regulated.
Excuse me, but your time is a little over, so please move on to your conclusions.
Okay, so microRNAs could be ideal candidates for diagnostic and prognostic indicators for patients with gliomas. Development in microRNA brain tumors therapy is the promising prospect of the treating tumors in precise ways. For these reasons, microRNA definitely deserve future research. And most important microRNA glioma is microRNA 21, 222, 34A and 10B. And the aim of the therapy with microRNA in glioma is to restore the balance of the gene expression. And it allows to personalized treatment. And thank you for your attention.
Okay, thank you very much. So now it's time to start the discussion.
Could you tell us how many articles did you include?
I included 12 articles after the including and excluding criteria.
And what were the inclusion and exclusion criteria for your study?
So I chose the articles, the systematic reviews, meta-analysis, and clinical trials only. The articles were from 2019 and 2023. All of these articles was in English. And they were they were only about microRNA in glioma. They didn't include any other treatment options or biological or biomarkers for glioma.
Okay, and what was your personal input in the work?
Personal input.
Personal input. What part of work did you do?
Okay, I understand. So I researched I researched the articles, and I was my part of the job was to analyze the biomarkers, and my partner analyzed the treatment methods.
Okay, thank you very much.
Thank you.
Do you know what is the reason that gliomas are diagnosed so late?
So I think that at the beginning, when the tumors are small, the symptoms aren't so strong. So the headache is the most common. So the headache is the most common symptom, and people often they go to the doctor too late when the glioma is big, and it is difficult to surgical resection. Sometimes it isn't possible to resect it.
Yes, thank you.
Thank you for the discussion and for your work.
Thank you.
And now it's time for the next presentation. If we have authors of the effect of protein intake on the kidney condition of athletes, do we have? Okay, so we will. Now I'll show you our screen. So I think now it works, so you can start when you are ready.
Witam Szanowną Komisję oraz wszystkich zgromadzonych. Nazywam się Anna Zabochnicka i jestem uczestniczką Koła Naukowego Dietetyków w Śląskiej Wyższej Szkole Medycznej w Katowicach. Tematem mojej pracy przeglądowej będzie wpływ spożycia białka na czynność nerek u sportowców. Białko jest niezbędne do prawidłowego wzrostu i rozwoju organizmu. Pełni przede wszystkim funkcje budulcowe, ale także immunologiczne, transportujące, hormonalne czy enzymatyczne. Przy niedostatecznej podaży energii białko może pełnić również funkcję energetyczną, lecz jednak nie jest to jego główna funkcja. Zapotrzebowanie na białko u zdrowej dorosłej osoby o umiarkowanej aktywności fizycznej wynosi 0,9 g na kilogram masy ciała. Jednak są to wartości niewystarczające dla osób intensywnie trenujących i sportowców. Zwiększone zapotrzebowanie na białko w sporcie wynika m.in. z konieczności adaptacji do treningu oraz wzrostu wydajności, także regeneracji mięśni uszkodzonych treningiem, utrzymaniem wyższej masy mięśniowej, syntezie nowych białek mięśniowych, ale także wzmacnianiem struktur, takich jak ścięgna czy kości. Zapotrzebowanie na białko w sporcie ma wpływ m.in. skład ciała, podaż węglowodanów w diecie, podaż ogólna wartości energetycznej diety oraz stopień wytrenowania. Sugeruje się wartości w zakresie od 1,2 do 2,2 g na kilogram masy ciała. W tym dolne zakresy rekomenduje się dla sportowców wytrzymałościowych, takich jak bieganie czy pływanie, a górne zakresy dla sportów kształtujących sylwetkę, jak na przykład kulturystyka. Zwiększone zapotrzebowanie na białko jest korzystne w okresie deficytu energetycznego. Wiąże się z mniejszą utratą masy mięśniowej. Międzynarodowe Towarzystwo do Spraw Odżywiania Sportowego sugeruje spożycie białka w zakresie od 1,6 do 2,7 g na kilogram masy ciała lub do nawet 3,1 g beztłuszczowej masy ciała. Okresowe zwiększenie podaży białka może mieć zastosowanie podczas kontuzji. Białko może być także skuteczne w kontroli łaknienia. Równie ważne codzienna podaż białka ma znaczenie także jego poszczególna dystrybucja. Sugeruje się spożycie od 0,25 do 0,4 g na kilogram masy ciała w celu maksymalizacji syntezy białek mięśniowych co 3 do 5 godzin. W praktyce do oceny funkcji nerek używa się pomiaru kreatyniny w surowicy krwi. Warto wiedzieć, że jej wartość zależy od masy mięśniowej, także od diety wysokobiałkowej, szczególnie dużych ilości czerwonego mięsa oraz od suplementacji, np. kreatyną. Warto wiedzieć, że wzrost stężenia kreatyniny występuje na skutek odwodnienia, czy też nieodpowiedniego przygotowania się do badania, jak wysoka aktywność fizyczna przed badaniem. Do innych wskaźników zaliczamy wskaźnik szacowanej filtracji kłębuszkowej, wskaźnik azotu mocznikowego czy cystatyny C, która może być przydatnym wskaźnikiem osób, które mają wyższą masę mięśniową, gdyż w przeciwieństwie od kreatyniny nie jest zależna ani od masy mięśniowej, ani od stopnia nawodnienia. W 2015 roku przedstawiono badanie, gdzie sportowcy spożywali od 2,2 do 3,4 g na kilogram masy ciała przez okres 8 tygodni, jednocześnie wykonując trening oporowy. Po tym okresie nie zanotowano żadnych niepokojących zmian w parametrach krwi świadczących o pogorszeniu funkcji nerek. W 2016 roku opublikowano badanie trwające 4 miesiące przy stosowaniu diety bogato-białkowej na 12 wytrenowanych mężczyznach. Również nie wykazano żadnych niepokojących zmian w stężeniu kreatyniny, EGFR czy też azotu mocznikowego. Jednak są to krótkoterminowe badania, więc w 2016 roku opublikowano badanie trwające aż rok na mężczyznach trenujących oporowo, którzy spożywali białko w zakresie od 2,5 do 3,3 g na kilogram masy ciała, wykonując program treningu oporowego. Również nie wykazano żadnych niepokojących zmian. W 2018 roku opublikowano badanie na kulturystach. 5 wytrenowanych kulturystów przez okres ponad 2 lat stosowało diety bogato-białkowe w zakresie powyżej 2,2 g na kilogram masy ciała. W tym jeden z uczestników spożywał aż 5,1 g na kilogram masy ciała. Jednocześnie śledzone były podaż białka przy pomocy aplikacji MyFitnessPal, a uczestnicy otrzymali odżywkę białkową w celu uzupełnienia dziennej podaży białka. Dodatkowo co 6 miesięcy mieli wykonywany panel badań metabolicznych, tak jak glukoza, pomiary funkcji nerek, jak kreatynina, EGFR czy enzymy wątrobowe. Analizując średnie dane grupy, nie wykazano niepokojących zmian, jeżeli chodzi o wskaźniki funkcjonowania nerek. Natomiast analizując dane indywidualnie, 4 z uczestników miało lekko podwyższony azot mocznikowy, a 2 stężenie kreatyniny. Jednak warto wiedzieć, że na te parametry mógł mieć wpływ intensywny wysiłek fizyczny przed badaniem, a uczestnicy nie zostali poinformowani o tym, czy mają odstęp zachować między badaniem, czy nie. Uczestnikami byli wytrenowani kulturyści, a prowadzący badanie nie poinformowali ich, ani nie kontrolowali intensywności treningu. Jednak analizując średnie dane grupy, nie wykazano wpływu negatywnego spożywania diety bardzo wysokobiałkowej powyżej 2,2 gramów na kilogram masy ciała przez okres 2 lat u zdrowych osób. Kulturystyka jest sportem, który w praktyce stosuje żywieniowe i pozażywieniowe praktyki mogące uszkadzać nerki. W tym obecność sterydów anabolicznych stosowanych u kulturystów może zaburzać porównanie badań takich jak cystatyna C czy kreatynina. Także zaobserwowano częste stosowanie diet bogatobiałkowych u kulturystów, którzy mają jakieś dysfunkcje nerek, jak przewlekła choroba nerek. Pomimo iż przedstawione wartości są wyższe niż dzienne zapotrzebowanie najwyższe rekomendowane w sporcie, nie wiadomo, czy to właśnie dieta bogatobiałkowa miała wpływ na uszkodzenie nerek, czy też czynniki współistniejące u kulturystów, jak na przykład stosowanie sterydów androgenno-anabolicznych, czy stosowanie bardzo dużych dawek witamin A, E, D, czy także stosowanie leków niesteroidowych przeciwzapalnych oraz diuretyków przed zawodami, które mają na celu maksymalne odwodnienie, wskazanie waskularyzacji mięśniowej oraz uwidacznienie masy mięśniowej. Meta-analiza z 2018 roku nie wykazała wpływu negatywnego na zdrowie nerek u osób spożywających więcej niż 1,5 grama na kilogram masy ciała, u osób oczywiście zdrowych. To samo potwierdza przegląd systematyczny z tego roku. Nie wykazuje wpływu obciążenia białkiem wyższym niż 0,9 grama na kilogram masy ciała do nawet 3,3 grama na kilogram masy ciała u osób zdrowych, a zmiany obecne w wynikach badań, jak hiperfiltracja kłębuszkowa, wynikają z normalnych adaptacji i są bez znaczenia klinicznego u osób zdrowych. Światowa Międzynarodowa Organizacja Żywienia Sportowego sugeruje spożycie białka w zakresie od 1,4 do 2 gramów na kilogram masy ciała. Jest to całkowicie bezpieczne i korzystne. Przedstawione badania nie wykazały szkodliwości stosowania diet wysokobiałkowych przez okres do 2 lat, jednak obecnie... Tak, to już... Podsumowując, badania przeprowadzone nie wykazały szkodliwego wpływu spożycia białka przez okres do 2 lat na czynność nerek u zdrowych osób trenujących oporowo. Natomiast Międzynarodowe Towarzystwo Odżywiania Sportowego sugeruje spożycie białka w zakresie od 1,4 do 2 gramów na kilogram masy ciała. Jest to bezpieczne i korzystne. U kulturystów niekoniecznie dieta wysokobiałkowa mogła wpłynąć na uszkodzenie nerek, ale inne czynniki takie jak m.in. stosowanie sterydów androgenno-anabolicznych oraz potrzeba dalszych, długoterminowych badań mających na celu wpływ długotrwałego, trwającego nawet dziesięciolecie, obciążenia białkiem na nerki u zdrowych osób trenujących oporowo. Dziękuję.
Dziękujemy bardzo. Przejdźmy teraz do dyskusji.
Czy znaleźliście może artykuły, w których ta podaż białka była wyższa niż 3,5 grama?
Dziękuję. Starałam się wybierać artykuły, w których podaż białka była wyższa niż 2,2, wyżej niż 3,1 w niektórych artykułach. Niektóre osoby po prostu pojedyncze jednostki spożywały nawet do 5,1 grama na kilogram masy ciała, aczkolwiek tych badań nie było dużo. No, nie znalazłam zbyt dużej ilości badań, aczkolwiek nie wykazano aktualnie wpływu tego typu obciążeń białkiem na negatywny wpływ na nerki u osób zdrowych. Natomiast no, to były krótkoterminowe badania, a jeżeli były jakieś uszkodzenia, to te osoby mogły niekoniecznie wiadomo, czy właśnie białko było przyczyną uszkodzenia tych nerek, czy inne czynniki właśnie współistniejące, tak jak stosowane leki, sterydy, czy inne praktyki odwadniające na przykład.
A ja mam takie pytanie, chciałabym się zapytać trochę więcej na temat sposobu selekcji i metodologii selekcji artykułów wykorzystanych w przeglądzie.
Starałam się przeglądnąć artykuły z zakresu badań klinicznych, meta-analizy i przeglądy systematyczne na przestrzeni ostatnich dziesięcioleci, w tym, że skupiłam się głównie na grupach osób, które wcześniej już trenowały oporowo, były już doświadczone w tym, miały świadomość dotyczącą swojego żywienia i ilości spożywanego białka, także trenowały oporowo, wcześniej już przebywały na dietach wysokobiałkowych rzędu te 2 gramy na kilogram masy ciała. No i takich badań obecnie potrzeba więcej, żeby wyciągnąć jakieś wnioski. Ogólnie 7 takich, które spełniały te kryteria, przez 10 lat udało mi się znaleźć. Scopus, PubMed, Springer i Google Scholar.
Jeśli chodzi o początek tych wyszukiwań, to ile miałaś artykułów na początku, z których zostało to 7?
Około 30 artykułów było na początku, natomiast nie wszystkie, większość z nich porównywało na przykład wpływ wysokiego spożycia białka na skład ciała, a mi zależało stricte na parametry obejmujące zdrowie nerek, a nie wszystkie badania obejmowały po prostu te zakresy.
Dziękuję bardzo. So thank you for the discussion, for your work. And now I'd like to come back to Marcin Goławski and your work. I think that you're with us now and you will be able to present your
Yes,
work.
I am.
Okay, so wait a minute and you will... Okay, so I think you can share just your screen. And when you're ready, you can start.
Okay. Yes. Okay. Yes.
So you present the work, the reassessed potential of SARS-CoV-2 attenuation for COVID-19 vaccine development, a systematic review update.
Yes, so good afternoon, everyone. My name is Marcin Goławski. I represent the Department of Pharmacology of the Faculty of Medical Sciences in Zabrze, Medical University of Silesia, Katowice, and I was the principal investigator of this systematic review update, as well as the original work this is based on. So, as we may know, the COVID-19 continues to be an ongoing health issue, although it is no longer necessarily considered a health emergency, and research into COVID-19 vaccines is still necessary as per WHO statement. So what are the currently used COVID-19 vaccines at least in the Western countries? Well, I think everybody knows this. They are intramuscular, mostly based on mRNA. They are spike specific, so no other proteins of the virus are included. They have high immunogenicity, although this tends to wane over time and through the appearance of newer variants. The safety profile is overall favorable, but there are some very rare and severe adverse events observed. But one solution to the COVID-19 vaccine problem is definitely underexplored, that is the live attenuated vaccines. And although one such candidate has reached phase 3 trials, actually no such results of those trials, phase 2, phase 1, were published yet. So actually to properly assess the potential of this type of vaccines in SARS-CoV-2, we would actually need to look at the preclinical data, the animal models, and this was the purpose of the systematic review, as well as to actually find the mutations that can successfully be applied to SARS-CoV-2. But how actually one attenuates the virus? Well, there are two main options. Either there is a serial passage, the classical method when we grow the virus until it accumulates enough mutations to stop being pathogenic, or there's a modern method where we engineer the virus for so-called reverse genetics, where we just need to define the mutations we want, and then we can get the virus, which is hopefully attenuated. So now to methods. This is an update of a review published on the 7th May 2022. We searched Scopus, Web of Science, Embase, and PubMed. The search date was 24th of March 2023. We used complex search keys and inclusion-exclusion criteria because there were a lot of works to be searched through. For the purpose of the update, just one person screened the titles and abstracts, and we included only the works which presented the results of experiments of attenuated coronaviruses in animal models. and we used sequence alignment to determine whether the mutation is applicable to SARS-CoV-2. So other coronaviruses were applicable, were okay, as long as sufficiently similar to SARS-CoV-2. And now to the results. So there were a total of 31 attenuation strategies and a total of 122 coronaviruses that were attenuated in animal models. 41 of the viruses were new compared to the previous version of the review, and 38 of them were based on SARS-CoV-2. So what were the most important findings? Well, first, it was shown that it is possible to incorporate several temperature sensitizing mutations into SARS-CoV-2 to create a very stable virus. It was also possible to exchange the spike of the SARS-CoV-2 into the Omicron variant spike. So this shows that live attenuated vaccines could be easily adapted to new variants. It was also shown that combining several attenuating mutations does not necessarily reduce the immunogenicity of the vaccine. It was also shown that, there were 2 studies that tried to establish a dose-response relationship, but actually the results were not conclusive. It may not actually translate well to human studies in this case. It was also shown that additional free attenuation strategies can be indeed applied to SARS-CoV-2 compared to the previous version. This indicates that it is important to determine what sort of attenuating mutations can be applied to which viruses which group of viruses, because that can accelerate the vaccine development during the pandemic. It was also shown that while the obvious method of administering live attenuated vaccine against SARS-CoV-2 would be intranasal, because you administer the virus where it can replicate and elicit immune response. But actually, intramuscular administration was shown to be possible, but the immunogenicity was actually quite low. It was also shown that live attenuated vaccines would likely prevent not just the infection, but also transmission. But there was also an evidence of sterilizing immunity. That is, if the animal was vaccinated with live attenuated vaccine and then it got the virulent virus, there was no increase in the antibody levels. So there was complete prevention of replication of the challenge virus. And now on to the general discussion of the findings from this and previous version of the review and the conclusions. So it was shown that live attenuated vaccines against SARS-CoV-2 and related beta coronaviruses like SARS-CoV, MERS-CoV, and murine hepatitis virus are highly immunogenic and efficacious in animal models. It was also shown that vaccines, live attenuated vaccines against SARS-CoV-2 can be genetically stable, and they have a very low transmission potential. This was determined in previous studies. And even a single dose would likely be sufficient for effective immunity. But actually, if one wants to administer more doses, then those may not be effective because you prevent the replication of the vaccine virus, and this won't add any additional protection. So this shows that for those live attenuated vaccines definitely could play an important role, but they have their own limitations. Thank you very much for your attention.
Thank you very much for your work. So now it's time to move on to discussion of your work.
A very nice presentation.
Thank you.
What kind of difficulties did you have during your research?
So I generally observed that the articles that report attenuated viruses, especially attenuated SARS-CoV-2, often have no clear indication in the abstract that actually the article concerns this. So it was necessary to create a very broad search keys for all of the databases and screen thousands of articles. And even this did actually left some articles behind because I found them outside my search. But it was actually, I had to include them manually. And actually, no systematic search is actually can be quite conclusive. But I think that I got pretty close. For the first version, I got a total of 4,000 records to be screened. And in this, for this particular one, I think it was, yes, it was 1,600.
Thank you. Okay, and I would like to ask, you actually answered for some part of my question, because I wanted to ask for your personal input in the work. What was your part of the work?
So I can say that I did pretty much the whole thing for both the first version of and the current update, aside from some record screening and general advisory roles, which others auto place. I conceptualized the studies, designed the search keys, performed the searches, performed most of the screening, extracted data, I interpreted data, and prepared the presentation and such.
Okay, thank you very much.
You're welcome.
Thank you very much. So that's the end of the discussion of your work. So you can stop sharing your screen. And now I'd like to ask for some more presentations which were left behind our session. So now I'd like to ask if we have with us the authors of the work Autoimmune NMDA Receptor Encephalitis as a Cause of Secondary Psychosis, a Case Study Review. So do we have those people like Maria Nowak or Michał Ciołek? Do we have them? I don't think so. More, do we have the work Benefits of Treadmill Training for Patients with Down Syndrome, a Systematic Review, like Michał Ciołek or Karolina Kamińska? I cannot see them. Later, do we have the two authors of three next works, Gabia Balandait and Enrica Matulaitel? I don't think so. And do we have the authors of the work Effectiveness of Therapeutic Drug Monitoring in Anti-Cancer Treatment, Systematic Review? Ilia Lastowecki, Karolina Jałowiecka, Kamil Możdżeń, Mateusz Kęska, Weronika Fidelus, Wiktoria Suchy. I cannot see. So now I think that all the submitted papers have been presented, and we will congratulate all of the presenting authors and participants of this session of systematic reviews and meta-analysis. At this point, I would like to ask the president of jury for a few words to sum up the session.
So thank you very much for all of the participants for your input. I am really amazed with the level of many of your articles, because it will be actually quite a challenge to choose and pick the right one, because as we all know, the systematic reviews and the meta-analyses, which unfortunately none of it happened today, but we know they are very tough and very time-consuming form of work. So I am very happy that we were able to listen to very various topic on that matter, and we are lucky to participate in this event today. Thank you very much.
Thank you very much for such nice words to all of us. We truly appreciate all your valuable comments, accurate observations, and work on presentation assessment. Now I'd like to cordially invite you all for the decoration and closing ceremony with the results announcement of SIMC 2023, which will be held in A3 Hall on the 19th of May. It's on Friday at 4:50 p.m. And now I'd like also to invite you to physiotherapy workshops, which are held here in this building, in another room, but I think even now here on the corridor. And also I'd like to invite you to the microbiology workshops, which are placed near, and hand masks workshops, which are held near the registration office, with also some massages too. And now, on the behalf of student scientific associations, I would like to thank you all for the participation in this session, and goodbye and see you on Friday.